Good afternoon, everyone. Welcome to this 16th webinar on the COVID-19 outbreak, of which the aim is, of course, to be better prepared for the COVID outbreak in Botswana by informing ourselves. My name is Vuylsteke. I'm a medical oncologist at UB, and as you probably know, I'm very concerned with the COVID outbreak, as our cancer patients are at an increased risk. As an introduction to the webinar series, please be informed that it is co-organized by the Ministry of Health and Wellness, University of Botswana, Botswana-Harvard Partnership, and Rutgers University. The sessions are obviously done by Zoom, and please mute your microphone if that is not done automatically. You can ask questions, please do ask questions using the chat function during the talk, and a moderator will monitor those questions for afterwards. The session is recorded and will be made available after the session on YouTube, and on the next slide you will see the page, both full recording and the slides. And we please ask you to fill out a feedback survey so that we can serve better in the future. So our speaker for today is Dr. Orapeleng Phuswane-Katse, and she is a public health physician currently working at the Ministry of Health and Wellness. She has over 8 years of experience in both clinical medicine and public health medicine. She graduated from St. George's University in Grenada in 2011 School of Medicine and has been working in Botswana since. So Dr. Phuswane-Katse is currently working in the Disease Control Division at MoH and is the case management lead during this COVID-19 outbreak. In 2015, she was the first medical doctor in Botswana to do the prestigious Mandela Washington Fellowship, which is a 7-week leadership initiative that was started by President Obama. She is the former vice president of the Botswana Yali Network, which is the network of the Mandela Washington alumni, and a board member also for the Botswana United States Alumni Association. Dr. Phuswane-Katse has a Facebook page. I invite you to go and have a look at it. It's nice. Getting the Facts Right with Dr. Phuswane-Katse, that's the title. And it aims to educate and empower Botswana to take control of their health. She also mentors students through the Africa Itute project, which is also on Facebook. Dr. Phuswane-Katse, the screen is yours.
Good afternoon, everybody. I hope I'm clear. Can you hear me, Peter? We're good. Okay. I'm currently traveling, so if my network is a bit sketchy, that's the reason why. We're currently on the field for the COVID-19 surveillance. So it's been pretty interesting, and it's been quite an interesting 2 weeks of the surveillance. Okay, so this is just a session overview. We're going to be talking about the COVID-19 surveillance, which is currently ongoing, and that's the outline of the presentation. We'll be looking at what the Sentinel surveillance is, the purpose, the teams and roles, responsibilities, the protocol synopsis, which is really what informed the current surveillance, as well as the Sentinel surveillance update on the ground as we are here. And also, it's without a doubt, we're going to have some challenges and mitigations. So we've had challenges, but the important thing is we've been able to get through them as we're going through the surveillance. So basically, we're not one of the first countries to start a Sentinel surveillance. It's been done by many countries. Australia has done one. So we're just one of the countries that are continuing to do the surveillance. And unlike what has been going on, which is a passive form of data collection, we're now moving on to an active form of data collection to see how the COVID-19 is in our country. And this is opposite to the passive surveillance, like I said, which we've been doing. And of course, because it's an active form, it's a lot more expensive and needs a limited number of sites around the country for us to be able to get our answers, because really the focus is to collect high quality data, which can be used to inform the pandemic going forward. Right now, we all are aware that is one of the hotspots. Running was a few weeks ago, probably still is, but we need to know what the landscape is around the whole country. So the functions of the surveillance are basically to collect data, to analyze it, to interpret the data that we're collecting and to disseminate it as well so that we can make decisions from that data that we're collecting. Currently, we are mostly at the analysis stage because we literally just started 2 weeks ago. Our teams have been on the ground for the past 2 weeks. So we're still in the first sprints of this 3 months marathon. So the purpose really, like I said, is to detect, isolate, and contain any cases of SARS-CoV-2 early and as actively as you possibly can. Right now, we're really waiting to see the cases that come up, and then we contact trace them and we contain them. But that really isn't giving us hotspots in various areas around the country that could literally tell us what is going on. And the Sentinel surveillance structure will include community sites. Those are buses, taxi ranks, tuck shops, private mortuaries, malls, and shops. And I'll get into more detail about those sites as we go along, as well as health facility sites, clinics, and hospitals, as well as our private health facilities. I'm sure many of you have seen our teams around different DHMTs doing the actual screening of participants. So this is not a one-man show. We are working with the Ministry of Health and Wellness. We're working with our known implementers or partners that we normally work with, as well as our district health management teams across the country. So this is the structure. We have the Ministry of Health and Wellness, which literally is the whole embodiment of the whole surveillance. Then we have national coordinators, which is largely the public health specialists from the Ministry of Health and Wellness, as well as some leadership from there. Then we have zone coordinators, site supervisors, and implementing partners or supervisors. So the role of the national coordinators basically is to manage and coordinate the implementation of the Sentinel surveillance across the country so that we could be able to reach our objective of detecting, isolating, and containing SARS-CoV-2 early. And then we have our district health management teams, which have zonal coordinators. So these are like the overarching body in the DHMTs because they provide oversight and quality assurance of COVID-19 surveillance through bi-weekly, weekly updates and site visits to the different sites that we have. They also conduct internal site monitoring of activities for compliance with Sentinel surveillance protocols, operation, and ethical standards. Remember, we're dealing directly with participants and we're actively following them and swabbing them. So some ethical standards need to be maintained as the process goes ahead. So we also have site supervisors who literally are overseeing our implementers on the ground. They oversee all COVID-19 daily activities in the community and facilities, and they are liaison between the DHMT leadership, the district leadership, as well as other implementing partners. We found that as we're doing this, we really needed to involve our district leadership as well as our structures that are within the communities. So we've been working a lot with the DCOSIs, the DCs, as well as the council members so that they could easily allow us to work with the communities that they're a part of. So the implementing partners, just to state, the implementing partners that we're working with currently is Bumi and ACHUP, as well as other partners in the districts that are willing to help. But the two main implementers that we're working with is ACHUP and Bumi. And basically we're working with healthcare auxiliaries, what we call field assistants, as well as nurses in the field. So what they do is they collect data forms, they enter data into RedCap, which is the system that we're using, which is directly linked to our DHIS2. They undertake screening of participants, they obtain consent, swabbing of participants, as well as conduct initial data quality checks. This is to ensure that every data that comes through is actually what we need to collect so that we don't have those gaps in our data as we go along. So they also identify cases meeting case definition. We'll talk more about the case definition as we go on. They collect specimen from cases, train other specimens for collection. They collect specimen using appropriate infection control practices, because remember, this is COVID-19, and if you have it, it's highly infectious to the next person. So we ensure that infection control practices are in place. They also prepare specimens for shipment to the lab, as well as ship specimens to the laboratory under appropriate biosafety conditions. We cannot do this without community mobilizers, because people need to know that we're out there and we're doing the surveillance. So the community mobilizers, which have largely been our health promotions office, mobilize potential participants to the sites, such as shopping malls and taxi ranks, where it's very difficult for us sometimes to get participants. And the liaison between the communities and the site supervisors. I think we know we've had quite a lot of stories, myths about COVID-19, the actual test, about how painful it is. So these are the people who are helping change the mindset to allow people to come in and get that test done. And of course, we cannot do this without the lab, because they're the ones who are literally going to be resulting and showing us what our landscape looks like. So they identify issues with sample collection, preparation, transport affecting lab results. They train personnel on proper techniques. They process specimens on a timely basis. They oversee the quality control, standardized testing, provide supplies, and complete data collection tools and report on sample data quality. So for every site with a lab, there is a particular personnel who's assigned to the field assistants, so that they could easily help them collect and record the right information for us to get all the answers. So, like I said, this was a surveillance that was guided by a protocol that was developed before, so that we could easily implement it. So the protocol's in synopsis, or basically the overview of the study for the SARS-CoV-2 Sentinel surveillance, aims to establish a nationwide prevalence of SARS-CoV-2 infection through surveillance in selected Sentinel sites across the 9 COVID zones in Botswana. We know that we've all heard of the COVID-19 zones which we've been using. So we're in Greater Francistown, Greater Silibipikwe, Greater Palape. We are in Chobe. We are in why am I forgetting some of them? We're in Chobe, we are in Maung. So we are spread across all the 9 zones that we have. So the protocol describes the SARS-CoV-2 global and regional epidemiology, study objectives, study sampling methods, data analysis, data collection, data quality assurance, data monitoring, and evaluation that will be conducted as part of the study, including a study timeline and dissemination of activities. So basically, to go through the study objectives, or what the surveillance wishes to do or wishes to inform, is to monitor the intensity and the geographic spread of COVID-19 or SARS-CoV-2 across the country. Right now, we know that Gaborone has been hit hard, but we don't know what the landscape in other regions are. Are we not getting cases because we're not testing enough, or are we not getting cases because there's no COVID-19 there? As well as to measure the prevalence of SARS-CoV-2 in the general population and mortuaries. We know the prevalence of many illnesses, for example, HIV. So I think it's time we know the prevalence of SARS-CoV-2 as well, because this is not an illness that is here to pass. It's going to be with us for quite a while. So those things need to be, the prevalence needs to be known, so that we can appropriately react to possible future outbreaks if they happen, or what will happen in the future. Some of the secondary objectives is to detect outbreaks among our frontline workers. Those are healthcare workers, including workers at points of entry. We have seen in Gaborone, and especially Princess Marina Hospital, we've had quite a number of our healthcare workers being affected by COVID-19. So we need to monitor the outbreaks and see how we can avoid them or how we can prevent them, as well as to detect SARS-CoV-2 among crowded areas in Botswana. We have our shopping malls, we have our bus ranks, which we know people use and commute to on a daily basis. So we need to be able to see what the situation looks like in those areas, as well as to identify risk groups for SARS-CoV-2 infection, the socio-demographic distribution, as well as comorbidities, as well as to describe the severity, mild, moderate, or severe, of the infection among the risk groups. Right now, we are going by what the world is saying, but we need to determine our severity as well. Are we mild, are we moderate, or are we severe at this point in time? So the study design and sampling, this is basically a cross-sectional survey, which is within selected Sentinel sites across the 9 COVID zones. And there are our 9 COVID zones. We have Greater Palape, Buteti, Chobe, Maung, Khanzi, Kalahadi, Greater Gaborone, Greater Francistown, and Greater Silibipikwe zones. And this is a study or a surveillance which started on the 1st of October and will be running until the 31st of December. The estimated sample size is 43,740 samples from the whole region. And these zones were literally were selected using multi-stage cluster sampling method. So the first stage of this method was to select localities, cities, towns, semi-urban villages versus rural villages. and this came up to 31 localities, which currently all of our teams are in these different localities, and we term them clusters or segregated, and they were segregated along the urban and rural divide. We needed to get that urban and rural divide so that we can see where the burden is, so that we can do our resource allocations better looking at those. And then after we found those 31 localities, the next thing we did was to sample within the selected clusters individuals from all the 7 stratas or occupational categories that we know using systematic sampling. So the number of study participants in each selected locality is determined using proportional allocation based on the size of the population of the selected locality. You find that when we get to Francistown, our sample size is a lot larger than when you get to Chobe or Kasane, and that's because you find more people there. And as of now, Gaborone is the one with the largest sites. I think Gaborone has a total of 20 sites, while Francistown is the second largest with 14 sites. And that's just based on the population and how it's spread across those areas. So this is basically a short schematic sample of how this came about. We have our 9 COVID zones, which led to the 31 localities and the 7 sites. And within those 7 sites, we'll be looking at the occupational categories that are there: the health facility-based one, police stations, tertiary institutions, malls, terminals, airports, as well as morgues. So the study population is basically community-based and health facility-based sentinel sites across those 7 occupational categories that we already spoke about. So in the community-based, we have 98 community-based sites, and these are 17 shopping malls, 14 transportation terminals, 24 law enforcement security officials, 24 private mortuaries, 10 points of entries, and 9 tertiary institutions. And for health facilities, we have 60 health facilities, and these are both private and public hospitals and clinics. So the occupational categories, we have the health facilities, law enforcement, mortuary, points of entries, public transport terminal workers, and these are the bus drivers and bus conductors, as well as the hawkers who sell around those terminals, shopping mall staff, as well as the tertiary institution staff. So these are basically the high-risk groups according to occupation that I've already mentioned. And as you can tell, these are people who have high risk because on a daily they're in contact with the with individuals who are coming either to get help or are just passing through. So this is why they were some of the groups that have come up. As we're going across the districts, one of the common questions we're getting is students are not included in this surveillance, and many other occupations are coming across to say they're not included. But what we needed to do at first was to get a good representation of the whole country and the risk group so that we can understand where the disease burden is. And other issues like students and schools are things that are on the pipeline and probably will overlap as the study continues. So what is the inclusion criteria, which goes back to the question that we are asked quite commonly. So for community sites, we were looking for any person who's above the age of 18, any person who works in a selected site and has provided verbal consent to participate. For example, if you are working in Gaborone bus rank, for example, you would be part of that surveillance and are above the age of 18. And if you are coming from Ramudzwa bus rank, which is not part of the site, we would not allow you to participate in the surveillance because you are coming out of a different locality. And then corpses brought in dead, especially with an unknown cause of death, who have been sent to a private mortuary or a sentinel site. So these are the BIDs, because this is, for example, somebody who was just well today and walking around, and then all of a sudden they fall down and die. So those are the people that we're looking for. And then for health facilities, it's any person 18 years and above residing in Botswana, any healthcare worker who works at the sampled health facility, For example, if Princess Marina Hospital is a sample site and you're coming from, for example, from Mafitla Kosi Clinic, we will not put you in the study because we only want people who are at Princess Marina Hospital. Any healthcare workers who works there is accepted into the surveillance. Any outpatients or inpatients who meet the criteria of case definitions of ILIs. For our ILIs, we're looking at acute respiratory infection with a measured fever of more than 38, cough with an onset within the last 14 days, or SARIs, which are severe acute respiratory infections, which is anybody who has a fever above 38, a cough, an onset within the last 14 days, and requires hospitalization. And any eligible patient and healthcare worker who has provided verbal consent is eligible to participate. So the key milestones that we're going with is you needed to be above the age of 18 and provide verbal consent. And for our selection criteria, we were looking with randomly selecting every fifth person who was coming along, especially for the taxi ranks, bus ranks, as well as the well patients. But for patients who were coming in symptomatic, everyone who was symptomatic and met the criteria of the ILIs or SARIs was included in the study. So the exclusion criteria is any person who's not working at the selected site, like I've mentioned before, anyone who refuses consent to the study, any corpses brought in dead with a known cause of death, and obviously everybody who's below the age of 18. And this is one of the things that made the schools not be included, because most of our students are still minors and they cannot consent for themselves. So we'd have to go through multiple stages to get assent from their parents, which might be a working process and probably shoot the study over the 3 months that is supposed to be. So the study procedures, before the surveillance began, all the study members were trained on the study protocol so that they understand and appreciate it. They were taught on how to conduct ethical research following good clinical practice principles. And all of them, the site supervisors and the testing team, selected the target population using systematic sampling at both the community-based and the Sentinel sites. Basically, what needed to happen was everybody who is going to be part of the surveillance, or who's going to be the team that works in the surveillance, needed to understand how to ethically conduct the study without impeding on the rights of the participants. So the survey focal person estimated the burden of the outpatients as well as the inpatient from daily patient records and healthcare facilities. What we're seeing happening as we go along is, for example, I'm in the Francistown, Peakwe, and the Chobe areas. You find that we might have had some targets in the hospital, but when we get there, the focal persons have decided where to go as long as they're not getting out of the bounds of the study and the objectives. And screening at each site will be done 3 times a week on designated days, Monday, Wednesday, and Fridays. So for all those 3 days, the study participants are there collecting data, and in between the days, that's where they're analyzing it, cleaning it, and making sure that everything goes according to plan. So the team will follow a defined weekly schedule, which is literally made by the zonal coordinators and the zone supervisors, as well as the DHMTs, because remember, we're working within somebody's ground, so we need to work well along with the DHMT managers. And all eligible patients will be asked for their consent to collect a specimen by trained personnel for testing and extend storage to the National Health Lab for future testing. So safety precautions will be adhered to during specimen collections, and all of our workers are provided with good quality PPE so that we protect them as well. Routinely collected clinical data will be used to assess the clinical outcome for SARS-CoV-2. As with any study, we're still in the starting phases of the surveillance. So it is coming up all right, but I think in the next day or two, we would have had our feet on the ground, and it'll be easy for us to see the proper picture of the whole country. So how are we going to analyze our data so that we can meet our objectives? So we will compute the overall prevalence of SARS-CoV-2. Remember, one of the objectives was to get the prevalence of SARS-CoV-2. And in order to monitor the intensity, we'll compute the percentages of people who tested positive for SARS-CoV-2 among those with ILIs and SARI case definitions. And to measure the geographical spread, we will estimate the prevalence of SARS-CoV-2 for each of the 9 COVID-19 zones, since we have used them as the strata. And in addition, the prevalence will also be estimated for the 31 localities within each zone. At the end of this study, we'd be able to know that Gaborone, Boteti, and Greater Francistown are affected more compared to the other regions. And like I said, this will help us inform how we allocate our resources, looking at the patterns in across the country. So for the secondary objectives, for us to assess the severity will be categorized using 3 levels: mild, moderate, and severe. And for each level, we'll describe the total number of patients who've been hospitalized as a result of COVID-19, those in ICU, HDU, and a total number of deaths that are resulted from the samples that we've collected. And the prevalence of SARS-CoV-2 will also be estimated from crowded areas like the bus ranks, mortuaries, and to estimate the burden of SARS-CoV-2 outbreaks among frontline workers, such as healthcare workers, at points of entries and security officers, will estimate the prevalence for each cadre so as to determine the group that may require intervention. We might be thinking nurses are more at risk, nurses, doctors, anybody who's within a health facility, but you might find that our immigration officers also have a problem with COVID-19. And this has become apparent because in our regions that have borders, we have issues with illegal immigrants who are crossing back and forth. So this might be another high risk group that is a direct risk to our immigration officers. And for all this, the data will be aggregated for all zones. So at the end, we'll be able to know, like I said, which zones are more affected compared to the other ones. So descriptive statistics such as proportion and percentages and means will be used for each variable depending on whether it's categorical or continuous to describe the characteristics of the study participants. We'll know how many men we had, how many females we had. And the continuous variables, computation of mean or median, will depend on whether the variables follow a symmetric distribution or are skewed respectively. We'll also estimate the prevalence by different demographic variables such as age groups, sex, education, and level of employment and medical history. And this will help to identify the groups with the highest disease burden. We'll also run tests for association to determine which of these variables are risk factors for SARS-CoV-2. Are we seeing that males are more affected than females? Are we seeing that unemployed people are more affected compared to the employed people? And this will help us really change our messaging as well to reach everybody. So teams have been in the ground, like I said, for the past 2 weeks. And we've had meetings with the DHMT management. We've had meetings with the district leadership. We've had meeting with the site supervisors and the field assistants to see how things are going. So currently all the 9 COVID zones have started. When we looked at the data before this presentation, the points of entries are the ones that are still a bit behind, but most of them by the end of the week probably would have started. But as of now, all the COVID-19 zones have really started. And it's really been helpful because you've had a positive response from the DHMT as well as the district leadership, because everybody's interested to find out how their districts are doing. Should they use resources more for COVID-19, or what should they do? And this also helped because they needed to understand or needed to appreciate the balance between COVID-19 and all the other outbreaks that they normally have. For example, in Pigwe, we had to sit down and rationalize use of resources, looking at the fact that they are starting a malaria season, which has already started, and there's COVID-19 on the other hand. How do we balance the two so that we can get good outcomes out of the surveillance? And community mobilization is ongoing for many of the districts because we're still getting a little bit of a pushback from the study participants who are really worried about the results of them being part of the surveillance. For example, you have taxi drivers complaining that if they test positive, that is loss of business for them. And those are some of the realities that we're dealing with and we are aware of. And I did mention that we've had some challenges, but every challenge can have a solution if we're all working together and have the same goal. So our isolation facilities are still behind, and this is something that everybody is aware of and we're working really hard on. But as a mitigation, we have our COVID-19 guidelines, which have home isolation as an option for the districts. And not only will home isolation help in terms of isolation facilities, but this will help acclimatize or get the communities to know and understand COVID-19 better, as well as to allow them to deal with COVID-19 from a community level. I think we've seen how we've won the war with many of our epidemics. If we look at HIV, for example, we started with everybody being hospitalized, but then we moved to community home-based care, where people were now being taken care of at home. And this is the same thing that we can do. And what we normally go around and tell them is if a person is in home isolation and they have that space, this is literally Botswana for 10 days, and every Botswana knows Botswana and appreciates it. We can use that one space until the virus is cleared, and you can go and integrate into the community. And this also makes them understand and appreciate that it's not as bad as they think it is, and they can actually take part in the fight against COVID-19. So lab turnaround time has also been a question that we get quite a lot to say. How are we going to ensure that we get the results within the 3 months that we have without any delays? So we've been strengthening lab capacity, personnel, and resources to make sure that everybody gets everybody gets to get their results on time. And one thing that we've had in the hospitals is, but if you're prioritizing COVID-19 sentinel surveillance, what about the patients who are here? We are working together as teams, and when our field assistants get into the facility, we really would like for the hospital management to allow them to do the tests for them. That way we're helping in a way, and we're getting the results for the surveillance as well. Some sample sites have been removed or have been still being thought about, because you find that, for example, in Francistown, we went to one of the taxi ranks, and we found that it was actually not as functional as it was before because of COVID-19. Many people are not mobile, so will not be able to get the sample sizes that we need. So what happens in that situation is we find other sites that we can use to be able to meet our sample sizes. Shortages of cars for the surveillance. This is something that we all know and we are aware of, but what we've learned is rational use of transport services is really important. For example, when we're thinking, or when you're imagining the surveillance, you would think wide and far, but most of the places are really close to one another. So what happens is you might end up needing one car for the surveillance instead of 4, or you might end up sharing. So we found that these are some of the solutions that were practical on the ground and we adopted. And mortuaries do not have adequate sample sizes. And on top of the mortuaries, the suggestion that we got from the facilities was, is it possible for them to swab at facilities instead of going to the mortuaries, because most of the BIDs pass through the hospitals before they go to the mortuaries. And what we advised was, this is it's the first 2 weeks and we're up and running. So any solutions that make sense to the DHMT and make them work easier is what we'll adopt. So mostly what is happening is now we're swabbing at hospitals, and we're working with statisticians to see how we can work around the numbers. The challenge is, for example, we were in Nata, and Nata receives only 2 corpses per week sometimes, and our sample size was 4 for that. So how do we make sure that we cover those sample sizes, or how can we make sure that we get to the numbers that we need? And job security and interruption of workers by taxi drivers and street vendors. Most of them are breadwinners of their families, and they're complaining that this will disrupt their work. So how do they go about testing without compromising their work? So the solution is really to improve the lab turnaround time so that they don't stay long, as well as public health education, so that they can understand that if they are not tested, they are spreading the virus even more. So it's best if they are tested and they know their status before being in the community. For example, a taxi driver takes about 4 people per ride, and if they are positive, they'll be spreading the virus to 4 people who will go into their families and spread the virus. So really, it's been a long 2 weeks, but it's a fruitful 2 weeks. We're seeing results. We're seeing a positive approach from the districts, and we're really getting quite a lot of help from the management, and this is really helping us a lot. So we just would like to thank the DHMTs for being so forthcoming and allowing us into that space to be able to do the surveillance, because ultimately we need to know which districts are hard hit and how we can help improve the services that are brought to those areas. I would take any questions.
Thank you very much. That was very informative. We had some questions that were sent to us prior to this talk. Maybe I can suggest that we go over those first, and then we go to the questions that were asked during the talk. So there's questions on the different areas, and I'm going to start with the questions on the protocol. So are we on track to reaching out to the proposed targets? And the second question is, can we suggest other sites not included? And apparent to that, what was the selection criteria used?
Okay. So far we can say we are on target, because as of this afternoon when I checked, we're currently at 2.2 samples that have been collected, and that is without adding the ones that came from today. Remember, most of the sites started about last week Wednesday, last week Tuesday, so we're still getting there. But when we project, looks like we'll be able to reach our targets. And do we think we can add some of the sites? The plan is for the Sentinel surveillance to continue after this. And the sites that have been selected for now are literally just to give a spread or an overview of what is happening across the country. So what we're really hoping for is to get data that will allow us to say the problems are here and there. And once the Sentinel surveillance starts from the Ministry of Health being spread across the whole district, then we'll include more sites or more areas that were not included in this initial phase.
All right, thank you. So one question is, how will the findings of the surveillance be used in the country's future COVID response plans? Like, concretely speaking, what can be changed?
Currently, I think one of the issues or one of the challenges that we had at the beginning was resource allocation. You find that most districts did not have enough resources to run the pandemic, or were not able to do what they were supposed to do. So what this will inform is how do we go ahead to ensure that every district is capacitated to be able to respond to COVID-19. For example, we might have 60 nurses in Gaborone when we actually need 10, and we might have 10 nurses in Chobe when we actually need 60. So looking at the disease burden, that is how we'll be able to spread our resources better, so that every district can be better able to look at the pandemic and control the COVID-19 within their region. And if you're looking at our objectives, or looking at the risk groups as well, you might find that nurses, taxi drivers in regions that have a lot of travel movement are affected more. So how do we work with taxi association to ensure that they're protected and they don't spread COVID-19 as much as the others? So I think at the end of this, we'll be able to know how to better control the control COVID-19 in the country, versus to what we're doing now with cases popping up and us following them.
All right, thank you. So there's a question on the study outcomes. When are the results for the survey expected? And then another question, with the increase of the number of cases, is Botswana considering to change the testing strategy?
The surveillance is expected to run. It's been running from the 1st of October to the 31st of December. So I think after the 31st of December, there'll be that time where we analyzing data and putting it all together. So probably after the 31st of December, that's when we'll get data. And as for the second question, I don't think I'm better suited to answer that one. What I can say is I think it's a novel disease, and we're progressing with the international community, and we'll see how we go about with our testing strategies as time goes on.
Okay. And on the study outcomes also, would Sentinel surveillance fulfill the COVID-19 strategy objective best in Botswana compared to other types of surveillance? So
right now, it's the only thing that we have to be able, because it's either we do the passive surveillance or we do the active, which is the Sentinel surveillance. And I think because it's a really short space of time with a limited number of sites, we'll be able to get the answers quick and be able to infer that data to the rest of the country to effect change whichever way we can.
all right. And then there's a questions on testing. How are the results for the positive cases released, and who is addressing the psychological issues after the results release?
Okay, so what the surveillance literally does is we are testing, and then we're working with the district health management teams. So we test, and then we ask you, do you want your test results sent to you via WhatsApp or an SMS? So you choose, and if you're positive and you need psychological support, then we connect you. The DHMT will help connect you with the psychological services in that district. So we understood that this is something that might have negative psychological impacts on people, especially if you're a breadwinner and you are away from your business for a long time. That might have some repercussions. So the DHMT is working hand in hand with us to connect those people to get the psychological support they need.
Yeah, in that sense as well, you talked about it for the drivers. It has a major impact if they are positive. And you said lab turnaround time, we're working on that, but I don't think, well, it's maybe not as much their concern, the lab turnaround time. Maybe their concern is that if in case they're positive, they lose 14 days of work. And they might prefer not to know it, thinking that they don't have it because they're asymptomatic, and therefore not knowing that they actually are infecting patients, people. So how are we going to deal with that?
And that's actually what is happening on the ground now. They would rather not know than be tested and find out that they're positive, because then they would have to stop business. So what we've been doing is working with the health promotion officers. We're showing them a point of view of, if you're positive, you're infecting the whole bus, or you're infecting the whole combi or taxi, and then you're going home to infect your family, and the people on your bus are going home to infect their families as well. So we're literally showing them how the disease can easily spread. And it's amazing how positive they've been. Once you try and tell them why it's important for them to test, and the support you will give them post the testing, then it really, really helps them appreciate why the process has to go on.
So there's another question. Thank you. There's another question on testing, but I think you've responded to it. Will the test be available as a rapid test, like the GeneXpert test, for use at areas like airports? But I think you don't test the people arriving. You test the people that are working at the airports, right?
The people that are working at the airports.
So there's no need for urgent testing in that case. So thank you. And then concerning clinical and public health, what are the factors responsible for the COVID-19 infection control getting out of hand at this moment? And what fuels the spread of coronavirus in Greater Gaborone?
I think it's expected that with any infectious illness, and at some point it's going to be a wildfire. It's going to go and spread until the curve comes down again. So I think that is what is currently happening. And as much as we would have loved to curb it or contain it, it's something that was bound to happen, as we saw happening in many regions of the world. So what we can attribute it to is non-compliance. I think it's quite simple, and we've seen it. People are not wearing their masks properly. People are not sanitizing properly. And when you get into a shop, half the time you get a dot of a sanitizer instead of a full hand sanitizer for your whole hand. So I think we are the drivers of the epidemic, and it's going to come to a point where our curve is really high and then it starts going down again. So it was something that epidemiologically was expected. How it happened and when is something that could have only been predicted by models. So I think we're at that time where we're seeing that surge in Gaborone. And I think a beautiful example is the running situation, where we saw the cases coming up really rapidly and then coming down again. And now they're at that point where they are flattening and they don't have as many cases as they did before. And that is probably because they're a smaller population compared to Gaborone.
Yeah, absolutely. I propose to go now to the questions in the chat box. One is here. Hello, would it not help to involve the private labs to help the public labs to improve the turnaround time?
Can you repeat that again? I'm trying to look for the question. I can't find it.
So would it not help to involve the private labs to help the public labs to improve the turnaround time?
That is something that could have been considered. But I think with the sample size that we're looking at and the strengthening that was done, anything is possible. We could have involved them, but for now, the labs that are currently running is our labs in our facilities and the National Health Lab.
All right. And then there's another question. So the massive screening or surveillance by the Ministry of Health will be determined by the findings of the study. The massive screening or surveillance by the Ministry of Health will be determined by the findings of the study, question mark.
The findings of the study will definitely inform the Ministry of Health on a lot of interventions, and what those are or what some of those are is really something that we'll get into it. Currently, the talk has been around flu clinics, to establish clinics in various sites so that we can get a good representation of what is going on. Mass testing might work, it might not work, but currently the surveillance is there to see which areas are hotspots and what other interventions can be informed from it.
So one question is also concerning the borders. So this, in Europe, the number of cases have spread from the main cities to other parts of the countries. And when the borders open, especially in the north, how will this be managed in Botswana?
I think what we're doing now is we are testing along the borders so that we could see how the burden is along those borders. That way you can strengthen them. For example, we know Tlokwen border is very busy. So definitely more services will go along those lines. Lobate is very busy, so services will go along those lines. So once the borders open, I think it will just be an issue of us testing more and being able to catch the cases earlier. And I think the surveillance will show that, okay, when we're looking at the areas, Palape is okay. You don't have to worry much about it. So when the borders open, you would know what to look at and what not to look at in terms of which borders to support and which ones not to.
Absolutely. And going from the border to the hospitals, I was wondering myself. So in the hospitals, I think all patients that come in are tested right away. Okay. So when they become positive, they become a positive patient, and I don't think they go into your survey, right?
What happens is we are looking at symptomatic patients and asymptomatic patients. So once you were testing within, for example, Nyangagwe Referral Hospital, and you test positive and you were in the hospital, then you become part of the surveillance. And that's because we are collecting data within those hospitals, and we need to know how many people in our hospitals are actually, how many of our patients are actually testing positive, either being symptomatic or asymptomatic. And this is why earlier I was saying this is also helping reduce the work burden for the healthcare workers in those areas, because now we're doing the testing for them, and all the positive patients and the negative patients go towards the surveillance. The care is then by the DHMT and the hospital.
All right. So that's what you also do retroactively. So if a patient was tested positive on entry and was asymptomatic, and it was done by the standard procedure of the hospital, it still will be in your survey.
No, then it's not. What we do is we only, the ones that we get confirmed from are the ones that go into the surveillance. We don't do it retrospectively.
Yes. So, but a lot of patients will already have been tested in the hospital, and so it will be, maybe there will only be a minority in the hospitals that will be able to be followed up, because they will only become positive during their stay in the hospital thanks to your test, right?
Yes, yes. But you find that we are getting quite a lot of patients testing in hospitals that have never had tests before. So I think we will reach our targets when it comes to the hospital targets, as well as the inpatient and outpatient targets.
Right. Maybe we can make some time for oral questions. Is that okay?
That's fine.
Does anyone want to?
There's another question. How can we find out which private health care facilities are included in the Sentinel surveillance? There is a list of hospitals that are included in the Sentinel surveillance that are private. And for every zone, there's a zonal coordinator, and the DHMTs would know. So it's always best to contact the DHMTs directly and find out which hospitals are included in the surveillance that are private. But it's not quite a lot of them, because we don't have many of those in our districts. So it's only a few that are included.
All right, thank you. There's also a question about interpretation and statistics, if you want to tackle that one.
Dr. Lesego, who is the statistician, is here, and I see he's been tackling quite a lot of them.
Yes, I did answer that one, Peter.
All right.
In terms of the one on the methodology, I've answered it. I copied it and pasted, and then presented the answer immediately after that. But yes, we do appreciate that there is a possibility of some selection bias, and then there exist, of course, methodologies that we are going to use to make adjustments for selection bias, such as inverse probability weighting. And then we will even also interrogate the data, whether we need even to go much deeper to address those type of bias, including using some techniques that even account for bias, such as a doubly robust methodology. But I think that one, yes, the answer is also presented there. Thank you.
All right. I'm not sure if I looked at all the questions in the chat, but maybe those that have not put it in the chat and I haven't seen it, maybe they can ask it orally now. Any questions from the audience?
People should feel free to unmute their mics when they want to ask a question.
All right, while we're waiting, just a very quick question. You're talking about phase 1 and phase 2. Phase 1 is like determining the clusters, and phase 2 is actually to those 7 subgroups. So phase 1 doesn't really include, doesn't mean that there's testing done during the phase 1. The testing is done in the phase 2 in those 7 subgroups, right?
Yes, technically speaking, the staging, the first stage was just to identify those localities, and then after that we went into the 7 occupational categories, which are the ones that we're now testing in those areas. One of the common questions we've had was, can anybody come? Can anybody be part of the surveillance? And that is no, because we already have a predetermined occupational stratas that we're using to enroll into the surveillance. The only people who are able to come is if you're being admitted or you're going to a health facility and you're getting help from there.
Yeah, and then there's a question in the chat again, so it's similar to the question that I asked on the hospitals. So will the cases identified be captured or counted separately from the ongoing passive SARS-CoV surveillance, which also captures positive patients like in the hospitals?
Okay, so what is happening is we have asked the hospitals to allow us to do the testing for them. So what happens is if Mr. X comes in and tests, they go into the Sentinel surveillance, and that data is routed through RedCap to DHIS2. So that person will only be counted once and not twice. So you will not be tested by the surveillance and by the hospital. You'll only be tested once by the actual surveillance. So the passive surveillance will not be ongoing then. So the hospitals will majorly be running with an active surveillance.
All right. Thank you. Still a few seconds for questions, if there are any. You're right. So that leaves me with thanking you for the audience. Thank you for the speaker with this. So we're now aware about this huge endeavor that you're doing in the country, and it's nice to see that the government people are really engaging into this in this fighting and preventing the spread of this disease. So I'd like to also thank Rutgers Botswana Botswana partnership for making this technically possible, and I encourage you to look out for future invitations, because this is going on as we are really in our first wave, and a lot of things are happening in the world that we are looking at. And hello.
I just had a thought.
Yes.
Yes, this is Dr. Mbengi. I'm just thinking, if from Sentinel surveillance testing, you get a positive case, and then the contacts for that case, what happens to them? Will they be included in that surveillance because they're from the same locality? Just in case from testing one case, you get a cluster outbreak in that zone, but the Sentinel surveillance won't show those other cases that came up from contact tracing. Thank you.
Thank you, Dr. Mbenge. So what is happening now is we are only looking at the primary contacts. So if you become positive, then the HMT is handed over the case to contact trace your contacts, but they will not be forming part of the surveillance, because imagine what would happen if one person comes up with quite a lot, then we would exhaust all of our numbers within a few months. So what is happening now is only those who are the primary positive contacts are the ones that stay in the study, and then the rest are handed over to the DHMT and are reported in the manner that is being used to report cases now. And I think if we were to realize that there's a cluster outbreak, then it will be taken care of by the DHMT in a manner that they've been doing already. And I think this is some of the things that we really, if you remember, our objectives are to detect, contain, and isolate early. So if we're able to identify that one person who leads us to 10 other cases, then we would have reached one of the objectives of the surveillance.
Thank you. So I'll take one last question that I see in the chat here. So what's your take on the turnaround time, as we already have delays with the current without the Sentinel samples, and labs already seem overwhelmed, and maybe the HMT already has a lot of work, particularly with contact tracing?
That is a very real issue on the ground, and it's one that we're addressing. So what happened is most of the labs had an extra machine being given to them, and also extra staff to help them look at the lab turnaround time. Those who are able to operate 24 hours are doing that, and those who cannot operate 24 hours are being capacitated to be able to operate 24 hours. And I think because this is an issue of national interest, we will see a change in the lab turnaround times. We'll see this also improving how things go on going forward, so that we can actually now have our clients getting their results faster than they used to before.
Okay, thank you. So let's stay tuned as we also are looking at the rest of the world, where Europe and the States are going to their second wave, and we really want to learn also from that. So please stay tuned for the next sessions, and I hope you have a very good afternoon, and please fill out the survey if you can take time for that. Thank you very much.
And thank you.